Great. Well, thank you so much, Anjali, and thank you everyone for joining us today. We wanted to first go through, before we get into the details of this study, a little bit of the context and justification for why CETA. And our team has worked in the field of global mental health for over 20 years. And through that work, I've had the special privilege of working directly with providers on a week-to-week basis, training trainers, working with supervisors. And in the beginning of our work, we really focused on what we call focal treatments, or treatments that really work with one problem or issue or challenge that clients are faced with. And across the board in all of my calls in multiple countries and contexts, what we've seen is providers coming to us with more challenges, that the clients that they're seeing have a range of stressors and problems that they're faced with. And as a result, from these different stressors and problems, the behavioral and emotional impact is often comorbidity. So as a counselor in the field, having treated multiple clients myself, supervised multiple clients and counselors as they're doing this work, I have yet to see I've seen very few cases that just have one area of symptoms or problems. We often see a combination of trauma and violence, depression, low adherence, substance use. And yet, despite this comorbidity, the current approach to providing services for mental, emotional, and behavioral health issues is a siloed approach. So in global mental health, many are still teaching lay providers different talk therapies that really just focus on one of these areas. And we started thinking, is this the best we can do? In our field, when we're working in these contexts where we have few people who could provide these services, really looking at how do we do it more effectively, more efficiently, and how do we do it at a lower cost so that it can be sustained? And so what happens with the silo approach is that to help a population to heal, we would have to train and roll out and implement a number of different treatments. And that's challenging at best and often impossible, and definitely not costly. So when we look at also the lay providers, it's just overwhelming. Even if we think about the providers that we have in the United States, learning multiple evidence-based treatments is just not easy to do. One solution for silo busting within our field of behavioral, emotional, and mental health is CETA, the Common Elements Treatment Approach. So CETA is built as a modular and flexible program. It has the ability to address multiple problems, not just one, not just two, but a wide range, including depression, violence, trauma, aggression, substance use, unhealthy alcohol use, safety, externalizing problems in youth, parenting problems, relationship problems, and actually soon we're hoping to add psychosis to that list. And research has shown in many clinical trials that we'll go over very briefly soon that lay providers can deliver this and address all of this comorbidity. So let's just take a really quick look at what is CETA. So CETA is not a new treatment. It's, as you can see, it's made up of existing core cognitive behavioral therapy elements that really have a wealth of data behind them. And what we do is we train providers and counselors in each of these elements and then how to put them together based on the client that they're seeing in front of them. So whether it's a client that has unhealthy alcohol use and trauma, or a client that has depression, we're able to pick and choose and help the counselors and providers pick and choose which elements to use. And given its design, CETA has great flexibility and can be taken apart. So we can actually remove one of these elements and provide it just as a brief intervention. For example, if you're working in the field with a lot of violence and suicide, we can train health workers in just how to do safety assessment and planning. And for more information on CETA, you can go to our website at cetaglobal.org, and there you can go a little bit more in depth into each of these different elements. So as I said, there's a lot of different evidence on CETA. We have been testing it since its development in 2010. We've tested it in multiple settings, contexts, and with many different populations. And what we've seen that it's very effective, delivered by lay providers in reducing mental health symptoms, reducing unhealthy alcohol use, as well as reducing frequency and severity of violence. So what's the takeaway from this? That CETA is an effective intervention for comorbidity. And that includes the treatment of unhealthy alcohol use, trauma, and depression. We also know that HIV risk behaviors and adherence are improved when patients have improved mental health, when there's reduced violence in the home, and when there's an increase in functioning and ability to problem solve. And there's currently studies being conducted to examine this link further. So how is CETA delivered? It's delivered by lay providers. So there's no advanced education needed. We look at training people that are, a minimum of 4th grade education. They just have to be literate in the local language. Clients receive, on average, 6 to 12 sessions, and the sessions last between 45 to 90 minutes. And providers have oversight by local supervisors and supervisors by expert trainers. And we really want to provide on-the-job continued training because we know that initial one-off trainings are just not effective in teaching and helping counselors really implement these interventions. So we provide that ongoing support as counselors do this for the first time. So I want to talk a little bit now about the different levels of care. We know that not all alcohol users need something like CETA. And there's different levels of use. So we have people that are abstaining from alcohol or use kind of low levels of drinking, that there are people with harmful and hazardous drinking levels, harmful and hazardous drinking levels with mental health comorbidities, and then we have people who have alcohol use disorders. And for each of these types of, or each of these levels of unhealthy drinking, a different intervention can be used. And so when we thought about doing this trial, we really wanted to pilot a system of care or a stepped care system. And to do that, we looked at developing a CETA brief intervention. So as I talked about, we can pull out certain elements of CETA, and the purpose of doing that is really, one, to provide an intervention for people who just have harmful and hazardous drinking, as well as to capture clients who have more needs, who might need something like full CETA. So let's take a quick look at what is the CETA SBIRT. So SBIRT just stands for Screening, Brief Intervention, and Referral to Treatment. And it's been found to be an effective approach for unhealthy substance use in high-income countries. What we did was just adapt our CBT for substance use reduction element to create this. And it consists of 6 components. First, we do an assessment with incoming clients to look at how much they're using. We understand the impacts of use. We explore how a client could want to change and then set a possible goal for that client. We help the client to identify their reasons for use, and based on their reasons, we really want to select a skill that can help them reach their goal for reducing. The CETA SBIRT can be delivered in 20 to 30 minutes by a health worker or lay provider, and we are looking at ways to actually do this over technology in the future. If a client is waiting in an HIV clinic to have their regular appointment, they would be able to do this over a tablet, hopefully in the future. And we use a structured guide called the Improving Health Worksheet to help lay counselors structure their sessions. So I just put up a very quick picture of 2 of the pages of this worksheet. And what you'll see here is, one, the table that really looks at how much the client has been using substances or drinking in the past 2 weeks. And then using visual aids and words, we help the client to explore how that use impacts them, both in positive and negative ways. And I don't have the full Improving Your Health worksheet up here, but we have sections like this for each of the different 6 topics or elements that we go over. So that just gives you a brief overview of the history of CETA and the development of this stepped care system for unhealthy alcohol users. And now I'm going to hand it over to Tukia, who is going to talk more about the initial qualitative work within the ZCAP study.
Thank you very much, Stephanie. So before we could roll out CETA into the health facilities, we really needed to understand its acceptability and also look at barriers and facilitators to its use within the HIV facilities. So we obtained approvals from various regulatory bodies, that being on ZBREC, from the province, from the DHO, and other public health bodies that also participated in the interviews. So our main goal was really, our main aim from this was really to understand, one, is CETA an acceptable treatment to people who are on ART? And secondly, to look at what are the barriers to its uptake within the healthcare facility and what are some of its facilitators. So what we did is that we conducted key informant interviews. So we interviewed policymakers from the Ministry of Health. We also conducted key informant interviews with experts, from one expert from an NGO. We also conducted focus group discussions with professional healthcare workers, lay health worker providers, and people who are on ART. So we did this at pre-implementation and post-implementation. We analyzed our data in vivo and we used thematic analysis, and this data was coded by 2 coders. So in terms of acceptability at pre-implementation, what we do see is that unhealthy alcohol use, as already highlighted by Dr. Sharma, is a very big problem that's really being faced in the ART facilities. Most stakeholders were of the opinion that patients who have a healthy alcohol intake often forget to take their medication. Therefore, the potential impact of CETA on the HIV cascade was seen as something highly beneficial to the ART clinic, and we're seeing a high level of acceptability within the HIV clinics. In terms of facilitators, the use of lay healthcare workers who have already psychosocial counseling skills was seen as a main facilitator for its effective use within the ART clinics. Looking at barriers, there were really main concerns were on the number of sessions that patients and both healthcare workers needed to attend. As Stephanie has already highlighted, CETA would involve a participant coming in for different sessions. So there was that fear, or in terms of looking at staff time. Another thing that really came up was the fear of stigmatization by providers and people and providers of who serve people on ART who have unhealthy alcohol use patterns. So before we could actually implement CETA, we took up some recommendations from our various stakeholders. So what we did to increase awareness, what we did is that we used our lay healthcare workers. So they provided health talks at the ART clinic to raise knowledge and awareness on what CETA was and what unhealthy alcohol use is. Secondly, we ensure that all our healthcare workers receive the certificate of participation immediately after the training of CETA, and we ensure that all our trained CETA counselors also, after successfully graduating at least 5 to 6 clients, receive certification on that. Another thing we did is that we ensured that participants knew they had the option to have CETA at the facility or location of their choice within the community. Lastly, we ensure that all our CETA sessions were accompanied by snacks to ensure that all our patients felt cared for and valued for. At post-implementation, we do still see this high acceptability of CETA. Patients and healthcare workers gained practical skills that they could use to manage and treat unhealthy alcohol use within the facility. So we do see that it was really highly beneficial for not only patients, but for the healthcare worker providers. In terms of facilitators, one thing that really appealed to the persons living with HIV was that CETA could be tailored to suit the participants' time. So for participants who worked through the week, we provided CETA on the weekends. In terms of looking at barriers, space came up as an issue. So and a thing that was really seen within this population, being an HIV population, is that many participants preferred facility-based CETA. So space was seen as a structural barrier to its implementation within the facility. And we just have some quotes from some participants, and here we do see some perceived benefits of CETA. So we do have a CETA recipient that was able to overcome suicidal ideation through their CETA sessions. Secondly, we also do see that CETA counselors were also able to gain skills which they could use to treat alcohol abuse and various mental health problems. So these are some of the recommendations that were arising at post-implementation of CETA. So one, we do see that there was, we do see a lot of participants saying that for future recommendations of CETA, there will be need to raise more awareness of it in the community. So for our specific study, we initially implemented CETA in the facility, and a lot of CETA recipients highlighted the missed opportunity of serving people in the community itself. So here you do see a lot of participants saying that for us to really make sure that CETA is known in the community, there was need to raise more awareness. And one strategy that really came up across most participants was the issue of using door-to-door campaigns. And here you see a quote from one of our CETA beneficiaries. Secondly, was the issue of transportation and incentives to encourage attendance. So to encourage attendance, it was suggested that the provision of snacks or transport or both would be needed to encourage attendance at the beginning. Once people had at least attended 3 to 4 sessions, they were motivated by the perceived benefits of CETA rather than the incentives itself. And here you do see a CETA beneficiary speaking of how they started to gain interest slowly in as they started their sessions. They might have started off not wanting to go, but as they continue to go for sessions, they gain interest in that. Another thing in terms of recommendations, as I earlier highlighted, the clinic was a preferred location for most of our participants, for most patients who are on ART. So a lot of patients said they were more comfortable with attending CETA sessions at the facility than a location within the community. And here we do see a quote from one of the participants that was on, or one of the CETA beneficiaries. So most of them felt the clinic was sort of a safe space for them to conduct their CETA sessions. And I think looking at our specific population, which is HIV patients, I think that it was avoiding the issue of double stigmatization, that's having both a mental health problem and having HIV. So most people were of the view that attending CETA at the clinic was more preferred to avoid neighbors or people around them asking questions. And lastly, in terms of recommendations arising, we do see the need to introduce CETA into the Ministry of Health establishment. So having CETA uptaken into a full-time basis and not just have it as a part-time, but have it into the system as a full-time basis. So in summary, what is the take-home message that we are getting from the qualitative work? One, I think the take-home message is both patients and healthcare workers highly benefited from CETA, and we see it in we see it from our qualitative work. Secondly, is that lay healthcare workers can deliver and provide CETA. Thirdly, while it's been implemented in HIV clinics, structural considerations such as tents, prefabs, space need to be considered by policymakers and funders. Lastly, finally, people in the community also needed to understand what CETA was before it can be fully taken up by members in the community. So there was need for a lot of people to understand what CETA was before it can be fully taken up in the community. Thank you all very much. I will now hand over to our next presenter, Dr. Jeremy Kane, who will present on the effectiveness of the trial itself.
Thanks, Takia. Let me just load my slides in. Okay, great. Well, thanks very much, Takia. Thanks very much, everyone, for being here this afternoon. So as Takia mentioned, I'm going to be talking about the quantitative phase results from ZCAP. So these are the results from the randomized controlled effectiveness trial that we did, where we tested both CETA and the brief intervention that Stephanie described that we developed for this study. And so as a starting point, I just wanted to kind of recap what we've said so far, our rationale for doing this trial. So epidemiologic studies have shown that there is a very high burden of unhealthy alcohol use among persons living with HIV in Zambia. And just to clarify here, that by unhealthy alcohol use, what we really mean, it's a very inclusive term that includes a range of different types of alcohol problems. So it includes things like alcohol abuse or alcohol dependence. It includes binge drinking, and it also includes heavy episodic drinking. And so studies have found that there's a very high prevalence of unhealthy alcohol use among persons living with HIV in Zambia. Studies have also found that comorbidity of unhealthy alcohol use, mental health, and other types of substance use problems are also quite high among persons living with HIV. Yet, despite this high prevalence, within HIV clinics in Zambia, as is the case in many places, there is no real standard screening or interventions for alcohol use or for mental health problems. And when interventions are available, they tend to be only one-session brief interventions. And so, while we think that rigorous evidence-based brief interventions, like the one that Stephanie described that we use in a study, may be helpful for some patients, they are only one piece of the puzzle because they're likely not sufficient for people who have more severe, more complex cases of alcohol use problems plus mental health comorbidities. And so our hypothesis was those types of patients would need something more substantial in addition to the BI, something like CETA. And so for our randomized trial, our main research question here was, what is the effectiveness of the BI plus CETA, so the two of them together, compared to the one-session BI alone in reducing unhealthy alcohol use, mental health problems, and other substance use problems among persons living with HIV? And the reason that we tested them together, CETA and the BI, is that we think that ultimately the BI and CETA could be used together within an SBIRT program, screening, brief intervention, and referral to treatment program that Stephanie described earlier in the talk. And so down the road, a program could include a screening for alcohol use within HIV care, followed by an on-the-spot one-session brief intervention, and for persons with more severe symptoms, a referral to higher level treatments such as CETA. And so we wanted to also see whether the results from our ZCAP study sort of supported this type of SBIRT approach. Okay, and so for the ZCAP trial design, we worked at Kanyama and Matero clinics, and we recruited persons living with HIV during their regular HIV care visits. We screened them for unhealthy alcohol use, as well as for mental health and other substance use comorbidities. And then if they screened positive for unhealthy alcohol use, we enrolled them into the study. So everyone in the study had unhealthy alcohol use, and many of our participants, but not all, had mental health or substance use comorbidities. Everyone in the study, all participants, received the on-the-spot point-of-care brief intervention as we would expect in an SBIRT program. And then half of our participants were randomized to be referred to CETA, and then half received no additional treatment after they got that BI. We then reassessed participants for alcohol, mental health, and substance use outcomes 6 months later. And so just to give you a bit more detail on the randomized trial outcomes, our outcomes included alcohol use, which was obviously our primary outcome, and it was measured with the audit screening tool. And then secondary outcomes included mental health problems of depression and PTSD symptoms, and we also measured other types of substance use. All of our outcomes were evaluated using what's called an audio computer assisted self-interviewing, or a CASI system. And what this means really is that instead of a person responding to an interviewer face-to-face about their alcohol use or mental health symptoms, they instead answered questions on a laptop computer and also had an audio recording of those questions read to them over headphones that they were wearing. And we chose this method, which we've used in Zambia for many years, because we found that participants can sometimes be more comfortable responding to sensitive questions like those on alcohol or substance use or mental health on a computer, as opposed to answering those questions face-to-face to an interviewer. And the pictures here on the screen just sort of show some photos of our Akazi in action. You can see how our participant would wear headphones during the interview and see the questions displayed on the screen. And so here's the flow diagram for the trial. We won't go through this in detail, but I'll give you the highlights. So we enrolled 160 persons living with HIV, all of whom had unhealthy alcohol use. And to get to 160, we only had to screen 180, which is an eligibility rate of 89%, which is very high for randomized trials. We also recruited in only a few months' time, I think really underscoring, really how high the need is within HIV care for these types of services. And so of those 160 people enrolled, 78 were randomized to receive the brief intervention, the BI alone, and 82 were randomized to receive the BI plus Citta. So we had a 100% success rate for completion of the BI. So all participants in the study successfully completed that one session BI, which was great news. And we had a 98% completion success rate for Citta. So we were obviously very, very happy to see that. And I think really does speak to its feasibility and acceptability in this setting. Now for the unfortunate bit of news. Remember that our follow-up visits were scheduled for 6 months after baseline. So by March 18th of this year, we had completed approximately 74% of our follow-up visits. On March 19th, we paused the follow-ups due to COVID-19, which was beginning to surge at the time in Lusaka. By that point, we had finished all intervention activities, so we were strictly in follow-up assessment mode. And we felt that it was, not ethical or appropriate to put our trial participants or our research staff at risk for purely research activities. And then, of course, by April of this year, it was becoming very clear that we were not going to be able to return to regular study activities for a pretty long time. And so we made the very difficult decision as a study team, and after consulting with our trial data safety monitoring board, that we would need to stop the trial early before all participants had finished. And so for analysis, we included only participants who had completed the study by March 18th. And again, that was about 74% of the total who were enrolled. And so we're happy in the question and answer session to discuss more about our rationale for stopping the trial early and why we think we were justified in doing that. But for the sake of time, we did want to jump right into the results and show you what we found. And so what you're looking at first here are alcohol scores as measured by the audit screening tool. Again, this was our primary outcome for the trial. And so at baseline, we had scores in the low 20s, right? Low 20s on the audit are very high audit scores, signifying pretty unhealthy alcohol use at baseline. Of course, not surprising given that this was our main inclusion criteria. And on the graph, the blue line represents the BI plus Citta group. The red line represents the BI alone group. And you can see we had pretty big reductions in alcohol use in both groups at the 6-month follow-up, right? In fact, within group change was statistically significant in both groups. But you see also that there is a pretty significant gap between the blue and the red line. And so we did also find both a clinically and statistically significantly greater reduction in unhealthy alcohol use 6 months post-baseline among those who received the BI plus Citta compared to those who just received the brief intervention by itself. And so the clinical effect size was calculated to be a 0.48. And so effect size rules of thumb are essentially that Anything lower than a 0.3 is a small clinical treatment effect. A 0.5, which is basically what we got here, is sort of a medium effect size. And then a 0.8 or higher is a very large treatment effect size. And so that was very encouraging, right? It indicated that the BI plus CETA was effective in reducing unhealthy alcohol use. And so here on the screen, we also observed significant treatment effects for reducing depression and PTSD symptoms. Depression is on the left of your screen. PTSD symptoms are on the right of your screen. And in both cases, we see a greater reduction in symptoms in the BI plus CETA blue line compared to the BI alone red line. Both of these were statistically significant findings. And so that was very encouraging as well. And then finally, we also saw significantly greater reductions in other types of substance use among those who received BI plus CETA compared to BI alone, including methamphetamine use, which is the upper left of your screen, marijuana use, which is the upper right of your screen, and then also an opioid use, which is in the bottom of your screen. In each case, we found meaningful decreases in the frequency of the drug use and the harm associated with the drug use after receiving BI plus CETA, right? We see a much bigger reduction in that blue line compared to the red line for these substance use outcomes. So very encouraged by these results as well. And then this is the last results slide that we'll share with you this afternoon. And to us really provides, I think, some important nuance about the trial results, and we think is suggestive for why CETA could be a really useful intervention in the HIV care context and why an SBIRT system might make sense. And so what we're seeing here is the change in unhealthy alcohol use with the audit screening tool. So this is the same outcome that I showed you in that first result slide. But this time the results have been stratified by the number of mental health or other substance use comorbidities that a person had at baseline. And so I'll walk through this, right? So starting in the top left, the graph shows people in the trial who at baseline had no additional comorbidities, right? They had unhealthy alcohol use alone. And here we see that the BI plus CETA performed better than BI alone. You can see the blue line is slightly below the red line at 6 months follow-up, but only by a very little bit, right? Here, the brief intervention alone actually seemed to do almost as well as the BI plus CETA, which we found to be very interesting. And then if you move on to the upper right of your screen, this is among participants with 1 to 2 comorbidities in addition to unhealthy alcohol use at baseline. So these patients also had something additionally like depression or PTSD symptoms or other substance use. And here we begin to really start to see that separation between the two groups, with the BI plus CETA performing better than BI alone, right? You see the blue and red lines begin to come further apart at the 6-month follow-up. And then in the bottom left of the screen, these are participants who had lots of comorbidities at baseline, 3 or more. And so these are patients likely who had unhealthy alcohol use, plus depression, plus PTSD, plus potentially poly substance use. And this is where the results were very, very striking to us, right? The BI alone red line is relatively flat, really not a big change in alcohol use among people with all of these comorbidities, but we see a sharp decrease among those who received BI plus CETA, the blue line. So CETA's treatment impact here was felt most strongly among these patients with the most severe complex cases. And the bottom right graph just sort of summarizes the clinical effect sizes of BI plus CETA by the number of comorbidities. So that green bar, a smaller effect size for people with 0 comorbidities, the effect size was about a 0.25, so relatively pretty small, but a much larger effect size for people with 3+ comorbidities, that purple bar. The effect size for patients with 3+ comorbidities was a 1.6, so a very, very big effect size there. And so what does this suggest to us? It suggests that although we have to show this in additional trials, that for people with unhealthy alcohol use but no comorbidities, the brief intervention, the BI, again, which was an evidence-based BI based on CETA's element, may be effective by itself, may be effective alone in reducing unhealthy alcohol use. But for people who have comorbidities, the BI followed by a more robust multi-session intervention such as CETA seems to be necessary. And so if we can confirm these results in a follow-up larger trial, we think that would really justify having a true SBIRT program or system in HIV care settings. And so I'm going to stop there. That'll wrap up our results slides. And so for the last part of our talk, I'm going to turn things over to my colleague, Mike Finnecore, who will go over some limitations, conclusions, and then our next steps.
Thank you all for sticking with us. Next slide. So although our study and our trial and the mixed methods we used had significant strength, there were limitations which we wanted to acknowledge. So as Dr. King just mentioned, we would like to believe that the brief intervention may be a good treatment for those individuals with unhealthy alcohol use, but without other comorbidities. However, we really did not compare that to to standard of care or to no treatment. And so therefore, we believe that additional evidence is needed to look at the true effectiveness of the BI alone. Secondly, a big limitation is that the study of this scope wasn't really prepared to assess impacts on HIV outcomes. And I know many people on this call are HIV program implementers or policymakers, and so we fully support the need to understand whether the reduction in alcohol use and the reduction in other comorbidities such as depression, PTSD symptoms, though whether those translate to improvements in retention, in care, improving adherence, and ultimately improving viral suppression and helping us achieve the goals of HIV treatment. And then finally, in this trial, all of our outcomes were self-reported, and so they are prone to a degree of reporting bias. Next slide. But in conclusion, we believe that that interventions such as CETA can be helpful for Zambia to take the next steps in achieving control of the HIV epidemic. So as most of you know, we're very happy that Zambia has achieved the 90-90-90 on schedule or even ahead of the schedule and the goals set out by UN/AIDS and other international stakeholders. And now we're looking forward to achieving the 95-95-95. And so I think that there is recognition that to reach the last mile, we're going to need to identify populations that are really not up to the 90-90-90 yet, and that could include people with unhealthy alcohol use and these comorbidities. Next slide. So in conclusion, CETA is a trans-diagnostic model. It's based on cognitive behavioral therapy principles, and it can be delivered feasibly by both lay and professional health workers in resource-limited care programs. Point two is that we found in this clinical trial that it was very feasible to deliver within the context of busy HIV clinics in Lusaka. We didn't discuss the clinics in great detail, but we selected large urban clinics in Lusaka urban that are very constrained in terms of staffing and infrastructure. And we also found that the therapy was acceptable to clients and very acceptable to the staff. Point number three is that BI followed by referral to CETA reduced unhealthy alcohol use when compared to the one-off brief intervention alone. And then final conclusion is that the work is not done, and a lot more information needs to be gained about these interventions, BI with and without referral to CETA, and that there's understanding the impact on the HIV epidemic, and also thinking about how this could be used in non-HIV populations still remains to be done. Next slide. So as for our team, we are trying to prepare for a larger trial, which would focus directly on the HIV outcomes of interest in Zambia. That would include adherence and retention in care, viral suppression, potentially other outcomes as well. We would also like to have longer term follow-up than just 6 months, because as many of you may suspect, we don't know whether the impacts are sustained in this study based upon the scope of our trial. And then there are a lot of implementation type questions to be answered, which we hope to tackle in a future study. And then as Ms. Skavensky Van Wyck mentioned, we'd like to understand whether an mHealth application could be used to deliver the alcohol brief intervention component, which would free up staffing time and hopefully provide similar effectiveness. Next slide. So this is just a brief acknowledgement of our core team. And we had a lot of support from within Lusaka district and from several of the ART departments. We worked closely with Ravi Pal from University of Zambia and partners at the Ministry of Health. Multiple universities in the US were involved, which helped in capacity building. And next slide. And finally, we just want to remember Mr. John Mayea, who many of you know, who passed away during the COVID-19 pandemic this year. And he has been working with our team for many years and was very encouraging of this study from the conception of the idea through to implementing the trial. And so we really miss him in this moment, and we just want to recognize his contributions to our work and to this area for the ZCAP study. And I think that's our last slide. All right, thank you very much for your attention. I really appreciate that most of you stayed on for the entire call. And I think now we're gonna go ahead with question and answers with the last 12 minutes that we have. So let me just start with the chat box to see if there are any questions. Let's see here. Okay, so there's a question from Janala Chipungu. The question is, did we assess the performance of the counselors, and can we speak to the strengths of the counselors in ensuring that participants benefited from CETA? So yes, we actually, as Ms. Skavensky Van Wyck mentioned, we had weekly supervision of the counselors, and during those supervision sessions, they discussed their cases and the challenges and the successes that they were having with the clients. They went over the data as far as the client's improvement of symptoms. And they also, by doing that, they were able to get further training, and the supervisor was also able to assess the counselor's performance. And so we were able, using this approach, to identify some high performing counselors who we actually then promoted onto supervisors during the later stage of the study. And so, so yeah, actually involving the counselor, supervising the counselors plays an incredibly important role in these type of interventions to assure that the maximum benefits are achieved. Let's see, there's a question from Wangelwa. What were the comorbidities that patients had? And unfortunately, I don't think we have a slide ready for this, but essentially the main comorbidities, the most common comorbidities were depression symptoms and post-traumatic stress symptoms. So these are symptoms that can develop after you experience trauma. Those were the most common. And then following that, actually, let me ask Dr. Kane to come in if he wants to add what are the other comorbidities that were common?
Yeah, so the comorbidities we measured were depression, post-traumatic stress symptoms, and other types of substance use. Within those, so there could have been other comorbidities that patients had in terms of mental health and behavioral health that we just didn't measure. But among those three that we did measure, the most common comorbidity was depression, followed by post-traumatic stress, followed by substance use. But I will say that it was most common for somebody to have at least one, if not more, comorbidities. So, you know, I think about 80% of our sample had at least one comorbidity, and many had two or three. So it really was sort of the rule and not the exception that our study participants had not just unhealthy alcohol use, but had other things that they were dealing with as well.
Okay, I think there's a few more questions coming into the chat box. If you have questions, please upload them to the chat box, or you can use the raise your hand feature if you have that on Zoom, and we'll get to you. We still have 6 more minutes, according to my watch. There's a question from Virginia, thank you. It says, considering that self-reporting isn't reliable in monitoring change, have you considered engaging community volunteers in follow-ups in their respective communities? So I think if I understand the question, it's that when a client indicates that they've reduced their alcohol use, how do you verify that? And so is someone checking up on them? Is someone you know, following them around to verify that they're not drinking again? And so no, we didn't really put that into effect for our study. And I think that you know, I'm not sure that that's really an acceptable way to manage these kind of patients. But we, you know, there are some alcohol biomarker tests available that could be considered in the future that could provide kind of more a more objective measure of alcohol change in alcohol use. And I would also say that the Johns Hopkins team have in the past also assessed alcohol use from the perspective of the partner. So, so basically engaging the partner or treatment supporter in the program as well. And then when you follow up with them, you follow up with the client to see how much they're drinking. And you also follow up with the treatment supporter or partner to see how much the client is drinking. And that provides another level of evidence on that. Great question, though. So next, there's a question from Monica. Were the counselors solely conducting CETA, or are they integrating their services with other HIV provision services? This is an excellent question. So we actually recruited peer counselors from within the existing structure. So, so we essentially posted a terms of reference with the help of the in charge in the departments. And then we conducted interviews and selected a group of counselors to be trained. And so these were essentially extra duties that they conducted on top of their other HIV care activities. So these same peer counselors were also providing help with patient providing adherence to the general clinic, tracing, and you know, enrollment in ART and various other services. So I think that's an important takeaway message that you don't have to necessarily bring in new staff for these kind of programs, that you can train up existing health workers. And most, if not all, of the counselors had no previous experience providing any type of cognitive behavioral therapy. And so that wasn't essential, and we were able to provide that to them within a short period of time. Great. Question from Meg Ito. Really exciting work. Oops, lost that one. Were the counselors age or sex matched to the client? So we didn't make that mandatory, but we did try to match up, if possible, women counselors with women participants and vice versa. Let me ask Steph Skavensky if she can to come in with this question about how essential is it that there's sex matching between the client and the counselor.
Sure, thanks, Michael. So we do the best we can on request for that to happen, particularly when a client prefers to be matched, but it's not always possible, and we don't see that it's always essential. We actually see that there can be a lot of healing and restoring in cases where it is maybe a female counselor with a male participant or a male counselor with a female participant, and that can challenge some of these unhealthy or unhelpful thoughts that clients have. But within this study, I would say that we did the best we could when requested. We always matched, but it wasn't always possible, but it did not have any impact on the outcomes for clients.
Thank you. The next question coming from Kapambwe. How were withdrawal symptoms managed, if at all? Were there such cases? And so this is actually an important consideration for people who are planning to use these type of interventions, that there is a subgroup of unhealthy alcohol users who will develop significant withdrawal symptoms. And those of you who are clinicians will know that you know, cold turkey alcohol withdrawal can actually lead to death in rare circumstances. So it is important to monitor. And so we work very closely with the hospitals where we're doing the study to refer, you know, to plan to refer anyone if they develop those symptoms. And so that's why it was really useful that we integrated ourselves into existing structures. But we actually didn't have any symptoms that warranted hospitalization during the trial. So it wasn't very common. However, in my clinical practice, I have experienced seeing those clients, and so it is an ongoing thing that needs to be monitored in treatments like these. Next question from Mashako. How can CETA help reduce violence and intimate partner violence in index testing? Is there a way this could be upscaled? Yeah, so there was actually, this is not the first trial of CETA in Zambia, it's actually the second. And the first trial, called What Works, which is, was published about 2 years ago, focused on reducing violence in women by engaging partners, male and, by engaging couples that had, where the female partner reported experiences of intimate partner violence and there was alcohol use in the couple. And so in that study, I'll refer you to look that study up. It's called What Works, or you can Google What Works Zambia. Violence was reduced with CETA compared to control condition. And so actually, we know that CETA is a very effective intervention for intimate partner violence. So that would be another benefit to bringing this intervention forward in Zambia. As far as index testing, I haven't really given that any thought, but I would just assume that if there are significant mental health or substance use symptoms that emerge from index testing, then consideration of this intervention, you know, could be made. All right, let's see. I think we have time for one last question. Let's see here. Okay, my question is, since the study ended during COVID-19, are there chances of having a similar study like ZCAP in the future? Well, we don't plan to try to re-identify those participants that didn't exit the study because of COVID-19. But certainly, I think COVID-19 has given us more thought into how to provide these treatments remotely, and how to screen and treat unhealthy alcohol use and mental health symptoms over the phone. And so certainly it has certainly pushed us to think about you know, alternative delivery modes rather than just face-to-face. But yeah, so I think we have to wrap up now. I'm very conscious of time, and thank you everyone for joining this webinar, and I hope you learned a lot, and we really appreciate the opportunity to share our data, which we hope will be further disseminated in the coming months and years. And we are very available for any follow-up questions. We've recorded this session, so if anyone has missed or would like to re-listen to it, please email Dr. Sharma or Tukia or any of us in the near future. We'll get you that information. And I see that Stephanie has put some links for the What Works study, which someone asked about, where they use CETA for intimate partner violence. And don't forget about CETA.org. Oh, sorry, CETAglobal.org. It's a website which has wonderful information about the intervention, and you can really see that it's being used increasingly around the world. And so, you know, it's very much becoming almost a standard of care type of program. Thank you very much, and we'll leave this webinar running just so you can copy those links, and have a good rest of the day and good rest of the week. Thank you all.
Thank you, everybody. Thank you, Dr. Venikor. I see some people are still on. I know it was a really interesting show, especially for us as well, to have different perspectives and questions. Our last picture was actually our peers, and I just wanted to acknowledge them, and especially their able supervisors and trainers, Chambalelo Mukanta and Elizabeth Mupenda. At this time, I'm going to take your permission to take my leave. Thank you. Bye-bye.